webinars. I did want to remind everybody that this is supposed to be a balanced educational webinar, and we will not give any medical advice. The purpose of this is to allow you to have a view of all of your options, especially if you have Fuchs dystrophy, and be better educated as you speak with your care providers about your disease. So without further ado, I'd like to just introduce our, maybe we can go over the agenda real quick. Introductions, I think I took a little bit less than 5 minutes. So I'm hoping that there's more time for questions at the tail end. We will welcome Dr. Sales and Dr. Goldstein, and I will introduce them in just the next slide, but they will take a few minutes to discuss different levels of the disease and what the treatment options are, and then we'll allow some time for a Q&A at the tail end. Next slide, please. So our featured speakers today are both cornea-trained surgeons. Dr. Christopher Sales is Associate Professor at the University of Iowa, and Dr. Michael Goldstein is Chief Medical Officer and President of Orion Biotech, and he's also a practicing cornea specialist at Tufts University. Dr. Sales, I'll hand it over to you at this point.
No sound.
You're on mute, Dr. Sales.
Is that better?
Much better.
All right. Okay. Thank you all for attending, and especially thank you to Orion Biotech for helping to assemble this. And I have to take a moment to personally thank Monica Bellizzi. I've known Monica by way of her husband for about 10 years now. And Bob, it was a really big part of my early career. And it was in part because of my conversations with Bob that I became really attuned to how much of a gap there was in terms of education for patients. And we slowly formed a relationship. And I wrote, a couple of things for Fuchs Friends that I think ended up getting a fair amount of traction with the community. As such, I think it's really important that I speak directly to all of the Fuchs Friends members and tell you all that one of the things, if you knew Bob, was that he's a straight talking guy. And he wanted people to be able to get the best information from their physicians. And he was really just trying to make sure that people have an opportunity to educate themselves enough to be able to ask the good, sometimes difficult questions to ask your surgeon. And he was never really in favor of one particular method versus another. He rolled with the evolution of how things went from penetrating full thickness transplants to DSEX and then slowly to DMEX, but he wasn't just jumping on the next thing as it came out. He was always a critical voice, and I always really appreciated that about Bob, and hopefully Monica feels like that I've represented that appropriately. And my role here as the non-Orion Biotech doctor is to make sure that I represent, I think, another voice. And I think I asked everyone before I joined whether or not that would be okay. And everyone said, yes, this is educational. And so I want you all to know that this is not biased in any way, at least, from the panel. Next slide, please. So, when we talk about the cornea, and it's particularly when it comes to Fuchs, we're really talking about that inside layer of the cornea, the endothelial cells. And this is what's thought to be, at least classically, where all of the issues are in Fuchs dystrophy. I'll complicate this a little bit and tell you that, in more recent years, it's thought that there's probably more effects of Fuchs dystrophy beyond just the endothelium. It's probably affecting the entire cornea to some degree, but for all intents and purposes, when it comes to intervening, it's an endothelial disease, meaning it's the inside layer of the cornea. Next slide, please. I think that was probably someone else's slides that I spoke through, but that's okay. So the corneal endothelial cells, when you look at them in a microscopic way, with specular microscopy, as you can see here on the right, they're basically hexagonal bricks on the inside of the cornea, and they have a couple functions. The way that I explain them to my patients is that the first function is that they're in normal patients, they're smooth, so they don't have any kind of interaction with the light when they're smooth. The second function is they're a water barrier. When they're nice and tight with each other, they prevent water from coming into the cornea. And then the third function is that they pump water out of the cornea. And that's sort of the topic of conversation that most people have with their surgeons. But there are those three functions. Next slide, please. The interesting thing about the corneal endothelium is that they're actually related to your brain cells. To the extent that you need to understand that is that when you lose brain cells, you know intuitively that they don't come back. When you lose endothelial cells, because they're of that origin in the body, they also don't come back, unlike other cells in the body. And so the important point to take home is that when you're born, you have a certain number of cells, and we measure them in terms of cell density. So 4,000 cells per square millimeter is what you're born with. And over time, you slowly lose those cells. And that's a natural process. And what I think is important for you all to see from that is that you can have fewer endothelial cells and not have a disease. Having fewer endothelial cells does not mean that you have a disease. But when you have Fuchs endothelial dystrophy, it's not just that you have fewer endothelial cells, but that your endothelial cells are not functioning as well as other people's endothelial cells. Next slide, please. So in Fuchs endothelial dystrophy, the essential issue that goes on is that you have a dysfunctional corneal endothelium. And when it comes to pump function, that means that the cornea itself becomes unable to keep itself totally clear as a result of an imbalance of fluid inflow into the cornea and fluid outflow from the cornea. So you can think about it in a most basic way as having a water pump that's not working in a pool, for example, and water's coming in, and now you have an overflow of fluid. In the cornea, when that happens, the cornea goes from being perfectly clear to less than perfectly clear. If I could pause for a moment, though, if you go on to the next slide. Let's talk a little bit about gutata, because if you remember those three functions that I described initially, one of them was having a smooth corneal endothelium. The second one was a barrier function, and the third one was a water pump function. Early in the disease in Fuchs endothelial dystrophy, you may not necessarily see a whole lot of pump endothelial dysfunction. You can find it in fine tests, but it may not be the predominant issue for a patient. In other words, patients won't come in with foggy corneas that are saturated with water, but what they will come in with is a bumpy endothelium with all of these gutata. And gutata are a fancy term for basically bumps on the inside of the cornea. And the way that I've described this in the packet that's been distributed through Fuchs Friends and into my patients is that you all understand this intuitively if you've ever looked at privacy glass on a shower. So if you've had privacy glass on a shower, you know that when you walk behind it, no one can see you like standing there naked, because that bumpiness that's on the inside of that edge glass is sort of scattering the light. And when it scatters the light, it decreases the contrast sensitivity. And it also makes it so that if you take a point source of light behind that glass, it will go from being a point source to being like an orb. And if you go on to the next slide, please. That is why you have this early set of symptoms in Fuchs endothelial dystrophy. Next slide, please. Where you have this kind of glare and halo. And one of the important take-home points, I think, from what I'm talking to you is that you can see an ophthalmologist and a cornea specialist and be complaining about glare and halos and have 20/25 vision and have an exam that does not at all look like this cloudy cornea, but actually looks like a cornea that's pretty clear. And that's because the early phases of Fuchs endothelial dystrophy don't present with lots of corneal swelling. And so one of the paradigms, I think, of Fuchs endothelial dystrophy is earlier intervention for earlier sets of symptoms that aren't entirely based in corneal endothelial dysfunction. In my own practice, I don't frequently see Fuchs endothelial corneal dystrophy patients with tons of corneal edema like you see here on the left, where you can't even see the iris details. We'll go back to the slide before that, please. I frequently see patients like this. Patients who have corneas that look clear, but they're telling me that they're not driving at night anymore, or they're having difficulty doing things that were important to them. Next slide, please. What DMEC and what DSO and now what these new therapies are doing is that they're shifting the goalposts, where once we used to have to only think about intervening on Fuchs endothelial dystrophy when people have severe corneal edema, and now we can intervene on it much earlier for symptoms that maybe someone would not have had surgery for 15 years ago. But now with these different kinds of techniques that are more minimally invasive and people can more reproducibly recover from rapidly, we've now started to intervene earlier. The take-home message from a genetic perspective on Fuchs endothelial dystrophy is that it's not entirely understood what the genetics of Fuchs are. And it's actually even thought that Fuchs may be a little bit of a bucket diagnosis, meaning that there may be different reasons for someone to manifest the same sort of clinical findings that we have, corneal guttata, endothelial dysfunction, but that there may be different genes responsible for it. And that's important because I think the next wave of treatments that are coming, treatments that don't involve surgery at all, are genetic treatments. And to do that, you need to understand what the genetic underpinnings are. But the genetics are somewhat complex. What is interesting is that there are interesting tie-ins between the genetics of Fuchs endothelial dystrophy and non-eye diseases, which we'll sort of leave on the side. But believe it or not, I think that's one reason why we may start to see more rapid progress in this part of the field. Next slide, please. What I tell my patients when they come into my clinic, particularly Fuchs Friends patients, if they've traveled to see me, and I have fewer of these patients ever since I moved to Iowa from New York City. But hey, you know, you're always welcome. The main thing that I try and tell my patients is that Fuchs endothelial dystrophy is this condition that is like a small little, you know, fire in a house, but the house is not burning down for the vast majority of patients. Because of organizations like Fuchs Friends, most patients are pretty well educated about what's going on, and they seek the treatment from their doctors, mostly just to establish care. And it doesn't necessarily mean that we're running to the operating room to do some kind of intervention. And so with you know, regular monitoring from your physician, you can feel pretty good that you're not going to go blind from Fuchs endothelial dystrophy. That's not something that happens in our corner of the world. It's certainly possible elsewhere, but the vast majority of people are really having conversations about quality of life, quality of vision. When is it the right time to do something? When you have symptoms that are affecting your life. Next slide, please. Most patients, when they come talk to me, are talking about those slides that are on the right, and to varying degrees. And I think some of that has to do with what people do in their lives, as well as what their tolerance is for having vision that's not quite perfect, as opposed to their risk tolerance for having a procedure. And this is different for different people. And anyone who saw me in New York when I would see a lot of Fuchs Friends patients know that for me, and I got a lot of this from where I was trained with Mark Terry, there rarely is, except for when there's a really swollen cornea that's looking at me on the other side of the exam, there really are rare places where I would say definitively it's time to go to the surgery. At the end of the day, I'm a physician. I do what's right for my patients, and that starts with listening to their complaints and trying to understand whether or not they're affected by their disease or not. Next slide, please. The last topic here is about cataract. This is always the question that all patients want to ask, which is that I heard that if I have any kind of endothelial corneal dystrophy procedure, that I need to have cataract surgery, and it should go in this order and what have you. I'm going to leave this for Dr. Goldstein, but suffice it to say, the most important thing for you to know is that there's layering of imperfections in someone's eye. And so if you have a cataract that's a little bit yellow, that's going to be enough to cause a lot of the same symptoms as Fuchs dystrophy. You might have some halo around lights. You might have a little bit of dimming of your vision. You might have a loss of contrast sensitivity. Color may not be quite perfect. If you layer on top of that another cataract, but no one has two cataracts, and instead of having a second cataract, you just have a cornea that's less than perfect, now you have the interplay of those two layers. And when you have those two layers working with each other, if you fix one of them, you may or may not be totally happy because there's still that other issue. The other rub is that these two, you know, anatomical objects are 3 millimeters apart from each other. And it's very difficult to do surgery on one of them without having some impact on the other. And some of that has to do with style between surgeons and what they think about things. But that's the reason why there's such an interplay between the two pieces, and why a lot of surgeons have different viewpoints on those issues. It's certainly possible to railroad everyone in the same path, and that's not wrong. It's just, it's sort of one-dimensional. It's also possible where you treat every single patient like they're completely different, and that's not wrong either. And then there's everything in between. And I'll leave that for Dr. Goldstein. Next slide, please.
Thank you, Dr. Salas. And before I have Dr. Goldstein start, I just want to let you know that we are receiving your questions. Thank you. They're wonderful questions, and we'll do our best to manage them at the tail end of the presentation. Dr. Goldstein?
Yeah, thanks, Paris. And thanks to Fuchs Friends for hosting this educational seminar. And thank you all for joining. And we look forward to being able to answer as many questions as we can. So I will move to the treatment part. So Dr. Salas set things up nicely. But the question is, what are our treatment options, and what are things to think about? So as noted, what we're really talking about here is the back part of the cornea. The cornea has multiple different layers. And what we're really talking about is, what options do I have if I've got problems with the endothelium? So there was a question in the chat about having anterior basement membrane dystrophy or map dot fingerprint dystrophy. So that's something that affects the front of the cornea, or the epithelium and the basement membrane beneath it, called Bowman's membrane. So that's treated differently, and not what we're going to talk about today. Next slide. So I think the two main things to think about when you think about treatment are, one is this is really treated with surgery, and there are a number of surgical options, which we'll talk about. And two, for all these surgeries, with the exception of one, we need a donor. So, and it's a 1-to-1 ratio. For every cornea that's available, every donor that's available, we can treat one patient. So the first way that this condition was treated was full thickness corneal transplant, or otherwise known as penetrating keratoplasty. So with this procedure, we take a donor cornea and we transplant all the layers of the cornea. So it's the endothelial layer, the basement membrane, which is called Descemet's membrane, the stroma, which is the big area, the epithelium, and the basement membrane of epithelium, known as Bowman's. So all of those layers are transplanted, and it works really nicely, and we can restore clarity to the cornea. The biggest issues are, as we said, it's one cornea for every person who needs it, and we now have a full thickness incision all the way around, 360 degrees around, and that can heal in different ways, which turns the eye, instead of being nice and round, can take on an irregular shape, which can affect vision. Next slide. So as the field has evolved, lots of smart people were involved, and they said, well, wait a minute, if we're really most concerned with the back part of the cornea, and particularly the endothelium, why do we need to transplant all the layers of the cornea? Can't we just transplant the back of the cornea? So in sort of the early 2000s, this procedure called DSEC was developed. And with DSEC, we're just transplanting the back, call it the back third of the cornea. So it's the endothelial layer, it's the basement membrane layer for the endothelium, and a bit of stroma. And the way we do that is, again, we take a donor cornea, we take the back part of it, we roll it up, and then we put it into the eye, and we unroll it inside the eye, and then we put a bubble in the eye in order to get that graft to stick into place. So it's a really nice procedure. People can do really well with it. It has a huge advantage of we don't have that full thickness incision, so the surface of the eye is left intact. That means visual recovery can be much quicker than it can be with penetrating keratoplasty, and we don't have all those issues with astigmatism. The downside of it, it's pretty technically challenging to do it, and typically only cornea specialists will do this procedure, as well as all these procedures we're talking about. And you've created this interface between the host cornea and the donor cornea, and where there's the potential interface, there is the potential to lose some vision. And it turns out the thicker the transplant that you put in, the worse the potential of vision can be. And so that's led to, next slide, the most recent procedure is called DMEC. So you can think of DMEC as a thinner version of DSEC. So here we just transplant the endothelial layer and its basement membrane. So it's much thinner than the DSEC graft. We also take a donor cornea. We take just that very thin layer, we roll it up, we put it in the eye, put the air bubble in. So the rest of the procedure is very similar. The biggest advantages of DMEC over DSEC is the quality of vision that you can get can be better with DMEC compared to DSEC. The biggest disadvantage of DMEC versus DSEC is it's technically even harder. It's even a thinner piece of tissue to work with. And so unless your eye is very, very normal inside, it may not be the right procedure in those cases. With all of these procedures, there is a risk of developing a rejection immune response to the tissue that we're putting into the eye, just like you can with any organ. The risk, at a very simple level way to think about it, is the risk of rejection is highest the more corneal tissue that we put in. So no surprise, if we do a full thickness corneal transplant, the risk of rejection is going to be much higher than if we do a DMEC. And just to give you some numbers, relative numbers, so the risk of rejection over a number of years with a full thickness penetrating keratoplasty is about 20%. With DSEC, it's about 8 to 10%. And with DMEC, it's lower, as you can imagine, it's about 1 to 2%. So next slide. So there is another procedure that we should talk about that many of you are familiar with, which is called DSO, or decimate stripping only, or DWEC is another term that people use. What's very cool about this procedure is it doesn't require a cornea to transplant. So there isn't any tissue from a donor going into the host. So there is no risk of rejection, and there is no shortage of corneal tissue. The way this works is the central area of where the endothelium is diseased is removed or stripped. And then there's so Dr. Salas said that, and it's correct, that those endothelial cells, there's a certain number and you lose them over time. But what can happen is they can slide over. So if you remove the area of diseased endothelium and you have healthy peripheral endothelium, those healthy cells can go and slide over and fill in the gap where the diseased ones were. And you can actually get vision to come back. You can get the swelling to go away. Biggest disadvantage of DSO is that it only works in a very specialized form of corneal edema. So if you've got problems just in the center part of your cornea and your peripheral endothelium is healthy, then you may be a candidate for DSO. The other issue with DSO is it can take a while for the visual acuity to improve. So whereas DSEC and DMEC, you can get visual recovery in pretty quickly within a month or two. With DSO, it can take a number of months before the visual acuity improves. Next slide. So what are the big hurdles with current standard of care? And now, we sort of went through individual ones, but generally, so one of the biggest issue is supply of corneas. So just like there's supply problems with all organs, there is a supply issue with cornea throughout the world. So for every 70 patients who have a diseased cornea who need a transplant, there's only one cornea available. Now, this depends a lot on where you live. So if you live in Japan, for example, the wait list is somewhere between can be 6 months to a year. If you live in the UK, the wait list can be up to a year or more. If you live in Canada, it depends on what province you're in, but the wait list can be 6 months up to 2 years or more. If you live in the United States, we have the most extensive eye banking network anywhere in the world. And generally, if you come into my office or Dr. Salas' office, we schedule you for a corneal transplant. And we then call a number of different eye banks, and we can usually find a cornea that will work for you. It's rare that we'd need to cancel a surgery because we can't find a cornea available in the US, although it does happen once or twice a year, maybe. However, the quality of the tissue can vary, and there's lots of different elements that we look at, but one of those is age. And as you can imagine, in order to do a corneal transplant, we need a donor cornea. People are typically older. And so most of the corneal transplants we do are from older patients. And it turns out, not surprising, that if you can transplant younger endothelial cells, that can be better. And so there can be variation on age and a number of other things. As mentioned, the surgeries themselves are all technically pretty challenging. They are typically only done by cornea specialists. Again, in the United States, we're fortunate we have more cornea specialists, I think, than anywhere else in the world. But there can be problems depending on where you live, getting access to a cornea specialist. The procedures themselves, we talked about some of the issues in terms of transplant rejection. We didn't talk about bubbling issues. So with DSEC and DMEC, we typically put a bubble into the eye, and that bubble is designed to hold the graft into position, and that happens over the first 1 to 3 days after surgery. But sometimes those grafts detach, and we have to do another bubbling procedure right after the surgery within those first several days. From the patient perspective, while that bubble's in the eye, you need to lie on your back and sort of keep that position for up to 3 days. And if you have to do a rebubbling, it can be an additional several days. So it can be somewhat of a cumbersome recovery. Next slide. So what do things look right now in terms of disease severity and treatment options? So on the more severe end of things, people who need surgery, your options really were penetrating keratoplasty, but now are typically DSEK or DMEK. DSO sort of fits into patients, again, who are in that specialized group, so a little less severe. If you have centralized guttata or centralized edema, but healthy peripheral cells, then you could be a candidate for DSO. And then early stage, we haven't talked about early stage, but early stage, we're really talking about topical therapies, and many of you are familiar with Muro 128, which is basically a saltwater solution, and it's a hypertonic solution, so it helps to draw water out of the cornea. And we typically use the ointments at night when you're sleeping, because when you're sleeping, water can't evaporate from the surface because the eyelid is blocking water from getting out of the eye. So we put ointment in the Muro 128 ointment to draw water out of the cornea. And then during the day, you can use a Muro 128 drop to try to, again, help draw water out of the cornea. So these topical therapies are not disease modifying. They do help with the temporary relief of swelling of the cornea, and they can be very helpful for people with very early stage disease. And then there's the option of, go back one slide, cell therapy, which we will talk about. That's not currently approved in the US. But cell therapy really could fill a niche, starting with the most severe patients and even sort of treating some of the more milder patients as more experience is generated with cell therapy. And we'll talk about that in a moment. Next slide. All right, so going through the different options in a little bit more detail, starting with penetrating keratoplasty, there are several ways to do this procedure. So one way to do it, as shown in the slide here, is we put interrupted sutures in. So advantage of penetrating keratoplasty, again, is you can get a nice clear cornea, and that can improve the vision. Disadvantage, again, is each one of those sutures has to heal in a very similar way. And you can imagine if one suture is a little bit tighter and one's a little bit looser, then you get a bunch of irregularity, or otherwise known as astigmatism. And that can lead to some decrease in vision. And so for those of you who've had full thickness penetrating keratoplasty, often what you'll do is you'll come in, we'll measure your vision, we'll take a picture called a corneal topography, and then we'll try to modulate the astigmatism by modifying the sutures. This procedure takes about an hour. It's typically done in the operating room. You are on a lot of steroids and usually topical steroids to start, and it's tapered over a number of months. Next slide. So an alternative way to do penetrating keratoplasty rather than do individual sutures is to do a running suture. So the advantage of doing one sort of running suture, and we usually don't do, so there are some people who just do running sutures, but usually we do some interrupted sutures, and then we do the running suture around. It makes the procedure itself a little quicker when we do a running suture, and it also can lower the risk of developing astigmatism because that running suture can distribute the irregularity of the cornea more easily. Biggest disadvantage of a running suture is if that running suture breaks, it can be much more challenging. Whereas if one of the individual sutures breaks, we can often leave it alone, or you just put in one suture. But if you have a running suture that breaks, it can lead to additional challenges. The rest of the healing, et cetera, is very similar between a running suture and interrupted sutures for full thickness penetrating keratoplasty. Next slide. All right, so then DSEK. So again, DSEK is where we transplant the back, call it third of the cornea. There is no full thickness incision. So again, nice advantage in terms of the integrity of the eye. We're not doing anything to the surface of the eye. You don't have the same issues with astigmatism. If you look at the picture on the top right, you can see there are no sutures to work with, which is pretty cool. There's a little asterisk up there which shows a little hole in the iris with both DSEK and DMEK. We put a little hole in the iris, and that's to prevent any risk of glaucoma when we're actually doing the procedure. The risk of glaucoma is because of the air bubble that we put in the eye. The picture on the bottom there is an OCT image looking at the cornea from the side, and the arrow is pointing to the graft at the back part of the cornea. The procedure itself is a little bit quicker than what we do with full thickness penetrating keratoplasty. It's, again, typically done in the operating room, usually done with local anesthetic, and usually get medicines to relax you. We do use steroid drops after DSEK and DMEK, but much less frequency than we do with full thickness penetrating keratoplasty. So typically using steroid drops starting at something like 4 times a day and tapering down to once a day over about 3 months. And all of us have slightly different regimens. The risk of transplant rejection is slightly higher with DSEK versus DMEK. And as I said earlier, the visual acuity may not be as good with DSEK as it is with DMEK. Next slide. So this is DMEK, which again is very similar to DSEK, except the tissue itself is very is thinner. Again, we don't use many sutures with DSEK and DMEK. The time is very similar between DSEK and DMEK, although DMEK, again, because the tissue is thinner, is technically more challenging. With both DSEK and DMEK, as mentioned, we put the air bubble in the eye, and when things go really well, the air bubble does a really nice job. It puts the cornea exactly where you need it to be. And as mentioned earlier, sometimes and it can be up to 20% of all cases, we have to go in and put a new air bubble in, and in order to get the graft to stick into position. Benefits of DMEK over DSEK, lower risk of rejection, and the quality of vision that you get with DMEK is going to be better than the quality of vision you get with DSEK. Next slide. So this gives you some images of what this looks like. So that the cornea is all folded up in that little cartridge that's shown in the picture. There's a small incision made in the eye. I should say here the cornea is stained blue so you can see it. The cornea is placed, and so that's panel A. If we moved over to the top right to panel B, the cornea is placed into the eye, and then we've got to unscroll it, which is not trivial. And sometimes it unscrolls really easily. Sometimes we have to do a little bit more work. One of the tricky things is you can't touch the back of the cornea with the endothelial cells, or you damage the cells you're trying to put in. So you've got to unscroll it without touching the back part of the cornea. And like I said, there's a bunch of different techniques people use, and we get it unscrolled, which you can see in C. And then we want it to stick in that position. And so then we put a little cannula with air behind the graft, and we fill the eye with air. And the air then pushes the graft into position, and it holds the graft into position. And then the cornea starts pumping. And as it starts pumping, it attaches to the back part of the cornea. So that is the challenging part of it. Now, if you look at this eye, this is a very normal eye, other than the corneal edema. So this eye's got a nice round pupil. It's got a lens that's in good position. All the structures are in the right place. And those are the cases that typically are the easiest to do with DSEK or DMEK. Not everyone's eye looks like that. And there are some times where the lens is in a different position, or the iris is not perfectly round. And in those cases, it can be more challenging to put the bubble in the right place. And the bubble can even go behind the iris, which can lead to all sorts of other issues. So when people ask which procedure should I have, it really depends on the state of what your eye looks like, and different options, different ways that your doctor might treat a certain patient. And so these are really individual discussions that you should have with your doctor. Next slide. And then DSO. So as mentioned, that the really cool thing about DSO is that you don't have any tissue involved, so there's no risk of rejection, and there's obviously no shortage of corneas, because we don't need a cornea. The patient on the upper right is a good example. So that patient has some swelling or some haze, and just in the very central part of the cornea, but the rest of the cornea looks normal. So with this procedure, that central area is stripped and left alone, and then those peripheral endothelial cells slide over and fill in the gap and start to work. So this is a quicker procedure. It's typically also done in the operating room, but it probably takes about 15 or 20 minutes to do. You can also do it through a small incision, Some of you have had it, may also have been put on a Rho kinase inhibitor or ROCK inhibitor. These are drugs that are approved for glaucoma, but have another advantage in that they can help to move those endothelial cells around. So there are studies going on looking and saying, can we make the process of those endothelial cells sliding over quicker by using a topical Rho kinase inhibitor? So people will do DSO with or without the use of topical Rho kinase inhibitors. But with this procedure, you also need a steroid, although typically the amount of inflammation you get is lower than with these other procedures. Big disadvantage of this procedure is that it really only works if you have a very small area of central damage to the corneal endothelium. If you have sort of wider spread disease to your endothelial cells, DSO is not a good procedure for you. Next slide. All right, so then we'll move to corneal endothelial cell therapy. So this is the newest option. I believe it's the future. It's what we're working on at Orion Biotech. So we're one of two companies in the United States working on this. The other company is called MSL. I know far more about what we're working on than what they're working on, but the concepts are pretty similar. So the idea here is that we still start with a donor cornea, but from a single pair of donor corneas, we can actually take the cells, grow them in culture, so get them back to a point where they're replicating, get them to stop replicating, but we can treat up to 1,000 patients from a single cornea. So we can actually solve the worldwide shortage for corneal tissue with this treatment. The other really nice thing about corneal endothelial cells is because we've got such a high degree to scale up, we can be very selective in which corneas we take. And so we only use corneas from patients between the ages of 7 and 29. So everyone's getting tissue from a very young cornea. The procedure itself is much more straightforward than either DSEK, DMEK, or penetrating keratoplasty. It's much more similar to what is typically done with DSO, and I'll show you that in a moment. And what we do is we do the polishing maneuver, and then we inject the cells into the eye, and then you lie in your stomach for up to 3 hours. The procedure initially will only be used in patients with more severe disease, and then as we get more comfortable with it, there is the opportunity to use these cells for patients with earlier and earlier in their disease state. And there's a number of questions about cataract surgery and corneal transplants, and one of the judgments we always have to make is with anyone who's had cataract surgery, do we think the cornea will be too damaged from the cataract surgery and need to have a transplant, or can you do the cataract surgery alone? And that's a judgment. It's not easy, but there is a world where you'd say, I'm not sure, but at the end, why not put in some more endothelial cells just to give you some more? And that sort of would make this whole decision a lot easier if at some point in the future. The procedure itself is pretty quick, so typically under 15 minutes. We do inject a Rho kinase inhibitor into the eye at the same time we put the cells in. And as I mentioned, patients will lie down for about 3 hours. These are cells, so there is a risk of rejection. That risk of rejection should be lower since we're only transplanting endothelial cells and not anything else. And to date, with about 260 patients, I think, treated to date, we haven't seen any cases of graft rejection, although at some point we may have some. But we think that risk should be well under 1%. Next slide. So this is the procedure. We take a polishing tool, and instead of removing Descemet's membrane, you can remove Descemet's membrane in this procedure. We found that you don't need to do it. We do a polishing maneuver to polish the back of the cornea. We then do an injection into the front of the eye of the cell suspension, and then we immediately flip the patient over to their stomach, and the patient lies face down for about 3 hours. And then after that, you can go about your normal activities. Next slide. So there is a little bit of data that we've put out, and this is looking at vision, and we look at 3 lines of vision because that is widely considered to be a clinically meaningful improvement. It's what the FDA expects to see in clinical trials. And at 1 month, and so this is looking at 3 different trials, the Japanese trials, which were the initial trials, and then we did 2 trials in El Salvador. So comparing the data across the 3 trials, about 40% of patients at 1 month get 3 lines of gain, north of 60% at 3 months, and sort of around 80% by 6 months, and then north of that by 12 months. Next slide. So this is sort of an overview, a summary of what we've talked about, starting with sort of the most invasive procedure, penetrating keratoplasty, and moving across. I won't go through all of it, but you know, the biggest, I think the big take-home messages are corneal transplants require full thickness corneal grafts, DSEC and DMEC require partial thickness grafts, DSO requires none, and cell therapy is just endothelial cells, and then rejection risk is highest depending on the more corneal tissue that you inject. So highest with penetrating keratoplasty, lowest with DMEC. We think it's going to be even lower with cell therapy, but we haven't treated enough patients to confidently be able to say that, and zero risk with DSO. So with that, I will see what questions people have.
Thank you, Dr. Goldstein and Dr. Salas. Well, we have about 45 questions, in addition to the 20 that I have answered already, that seemed a bit milder. So I will start with some of the recurrent themes and recurrent questions. This is for Dr. Goldstein. One of the main questions that has come up is, can cataracts be operated at the same time as corneal endothelial cell therapy?
So yes. So if you have both cataracts and you have endothelial cell disease, then the discussion you should be having with your ophthalmologist is, should they be done? Should one be done? Should the other be done? Or should it be done at the same time? So we do it at the same time. We call that a triple procedure. And that is certainly one option. If you've got significant cataract and you've got significant endothelial disease, then perhaps a triple procedure where you do both at the same time is the best way to go. If, on the other hand, you've got really significant cataracts, but only a little bit of endothelial disease, then maybe cataract surgery is better for you. And then the reverse is also true. With cell therapy in particular, yes, it can be done as part of a triple procedure, just like penetrating keratoplasty or endothelial keratoplasty can be done. And there was a presentation at the recent meeting, the ESCRS meeting in Barcelona, where data was presented on a patient who had the triple procedure.
Thanks. And if you were, maybe this is for Dr. Salas, if you were to need both corneal surgery and cataract surgery, how do you stage it? Do you do one first and then the second? This is also a question that's come up quite a bit.
I think that in this case, you should have a conversation with your surgeon about what they feel the most confident doing, because at the end of the day, you want to do what your surgeon feels like they can do really, really well. And there's some surgeons who feel very happy to do all of them at the same time. There's some surgeons who prefer, for various reasons, to do one and then the other, and there are other surgeons who prefer to do one and then the other one and the other. I'll give you a sort of an example of what I mean by that. In someone who's had a history of refractive surgery, like LASIK, for example, and those people are out there, and then they also later in life figure out that they have Fuchs endothelial dystrophy. In those patients in particular, there's a good chance that when you fix their cornea, that there's going to be a change in their glasses prescription as a result of the interaction between the LASIK they had in the past and their Fuchs dystrophy. And in those cases, it's really advantageous to do the transplant first, whether it be a DMEC or otherwise, even cell therapy, for example, and then to go do the cataract surgery, because the cataract surgery is more likely to yield a very accurate result with respect to the lens that we put in the eye. So those kinds of specific situations, I think, make a difference. Another example might be if you have a cataract, but you have other comorbidities in your eye, meaning other problems with your eye that make the cataract surgery more difficult for the cataract surgeon. That cataract surgeon may decide, even though they do the triple procedure, to say, it's lower risk for us to do the cataract surgery first, understanding that we're going to make your cornea become more foggy for a short period of time, and then we're going to go ahead and do the transplant after that. And I think it's really incumbent upon you to have that conversation with your surgeon.
Thank you, Dr. Salas. a broad comment for the group too, as I've seen a lot of specific questions to your particular pathology. It is best to actually go back and address some of the questions that you may have that may be specific to you with a cornea-trained surgeon that is familiar with all the options that were discussed today. The next most popular question is for Dr. Goldstein. If you can speak to the timeline for approval for cell therapy, and also when there's a lot of patients on the chat that are interested in participating in the Orion trial, if you can talk about when phase 3 may be an opportunity for some patients to be involved in. And then the second part of that question is, when do we expect approval in the US?
Okay, a lot of questions there. So cell therapy originated from the work of Professor Shigeru Kinoshita at KPUM University in Japan. And he's been working on this for more than a decade, and he has data. We have, and that technology is what Orion Biotech has acquired. So we now have data for these patients for many for over 5 years, and some for up to 10 years. Based on that work, the drug was approved in Japan last year. In Japan, you then have to go through a reimbursement process, which was approved earlier this year, and we commercially launched the drug in Japan in September, so last month. That approval package was not adequate for the United States, and there was some additional work in terms of improving the stability and the scaling up of the treatment in the United States. So to get to that number where I said we can treat 1,000 patients from a single pair of donor corneas. So the US process is behind where it is in Japan. We have just completed a phase 1/2 trial in the United States, and we'll have data early next year. We're talking to FDA, and based on that data, we'll have to probably do 2 additional trials in the United States called phase 3 pivotal trials. Those trials will likely start in the third quarter of next year. And those trials typically last about a year. So once we finish those trials, we would then put the data together for the FDA and try to get approval. So it's a few years away in the US. So did I catch all the questions that you asked?
I think you did. One more follow-up to that is, there's some individuals that are interested in potentially going to Japan and receiving this therapy. Can you address that?
So yeah, so the trial is currently reimbursed in Japan. There is an opportunity, theoretically, that people could come from places outside of Japan and get the therapy. However, the number of doses being manufactured in Japan is limited, and at least for the next year and a half or 2 years, I think all the doses are spoken for. So I don't think there's any additional drug available in Japan for the foreseeable future. So unfortunately, I don't think that's going to be a good option. And our best option is really going to be to try to move as quickly as we can to a safely and in the most efficient manner, getting the drug approved in the United States.
Thank you. Another quick comment before I go to a question is that currently there are no active trials for corneal endothelial cell therapy, meaning there are no current trials that are enrolling. Just make sure that you're reaching out to us and keeping an eye on orionbiotech.com to see when the next phase 3 trial will begin enrollment. Another popular question that came up is if you have DSO, prior DSO or DMEC, could you receive cell therapy under the protocol of the clinical trials? We have typically excluded these patients. Dr. Goldstein, unless you have any additional comments for the time being.
Yeah, I mean, we've excluded them as part for the clinical trials for consistency, but yes, those patients would benefit from cell therapy potentially.
Okay, as I keep going here, give me one quick second. Dr. Salas, what is the expected lifespan of a DMEC?
That's a great question. DMEC has been around for more than 10 years now, and in the form that it's in right now, which is that it is prepared by an eye bank, loaded into a injector, and then injected into the eye by the surgeon. That form, which is really streamlined the surgery, that really hasn't changed for about 10 years or more, anywhere between 10 and maybe 12 years. So on those data, if you look at those patients and you look at how they're doing now, the vast majority of those patients are doing really, really well. And we have from various studies of large groups of patients, particularly out of the Frank Price group in Indianapolis, as well as the Mark Terry group in Oregon and others, Singapore and others. We know that these transplants are going for a very long time. One question that always comes up with our patients is, well, my cell count is going down. What does that mean for me? And I think the answer, unfortunately, is we're not really sure. And you could have low cell counts with a transplant that's been around for more than a decade, and it doesn't mean anything. And so one of the themes that I've hopefully put forward to everyone is that at the end of the day, with Fuchs, whether you're the first time walking into a clinic or whether you've had a transplant 10 years ago, the time to do something about your transplant that's not doing so well is when you feel like your vision's not as good as you want it to be. And I think that if you've had surgery and that's been successful for a good number of years, you should feel pretty good about it continuing to go on for a while. And I think it's great to hear that if you wanted to, whenever that happens, if it ever happens at all, that you could sign up for something like cell therapy, which I think is a wonderful thing. And I've told my patients that as well.
Thank you very much. We have 2 minutes left, and if Monica and the team allows, I'm happy to go an additional 5 to answer some of the questions. And likely what we will do is manage the rest of the questions on different platforms, which is obviously the Corneal Dystrophy Foundation, but also if you can advance one more slide, we do have contact information on the next slide here. And you can write any of your questions that are cell therapy specific to hello@orionbiotech.com. And our fantastic patient advocacy consultant, Tristan Moores, will do her best in managing those. Any additional questions, please go through the Corneal Dystrophy Foundation, and the great advisors there will manage those questions as well. Let me see if I can handle a couple of the more recent ones that just came in here. Dr. Goldstein, who is not a good candidate for corneal endothelial cell therapy?
It's a good question. And I think one of the advantages of corneal endothelial cell therapy is that it's a flexible procedure. And I mean, I think, at least we believe, any patient who currently needs DSEC or DMEC is probably going to be a potential candidate for endothelial cell therapy. The question will become, how early in the disease can we intervene? And I agree with what Dr. Salas said. I think we're treating patients probably later in disease than we should be, and we're looking for opportunities to intervene earlier. I think cell therapy has the opportunity to really be able to intervene much earlier in the disease with a meaningful therapy.
Thank you. Dr. Salas, this is for you. There's several patients on the chat that have had a couple of failed DMEC procedures. The question is, how many repeat DMEC procedures could you have?
I don't think I have a definitive answer for that, but I think it depends on what happened with the eye. So this is a very rudimentary analogy, but my patients know that I speak in analogies. You can take off wallpaper from a wall a few times and put it back on, window tint from a window a few times and put it back on. If the window's broken or if something like that major is going on, there are reasons why it might not work going forward. So I think it depends on the specifics of the situation. If everything else is equal, meaning there's no other issue, there hasn't been a problem during surgery, etc. Unfortunately, we know that transplants that don't work the first time are more likely to not work the second and the third and the fourth time. And that gets to another part of transplant science, which is that it's not just the tissue that's put in or the method of the tissue or the cells, but things on the recipient end, meaning the patient who's receiving them. And there's a whole nother body of science behind that. Because if we could predict who that person was, we would obviously not be doing it over and over again. We'd probably try and offer something that's different. And there are non-cellular therapies that are out there that have to do with barrier effects, and maybe that's another day. But it's a good question. I'm sorry if that's been the case.
Thank you. Another common question here is that there's a couple of patients that are in their 80s or potentially even older asking whether there's an age requirement or cutoff for considering corneal transplantation or any of the procedures that were discussed. Dr. Salas, I'll give that one to you.
I've transplanted everyone from late 30s to 97. And it works in all of them.
I see Dr. Goldstein is agreeing.
Yeah, I've transplanted someone 102 who was healthy otherwise and did very well. So no, I don't think there's an age requirement. I think with DSAC-DMEC, you need to be able to lie on your back for a period of time. So that's always fun to do that. And then someone says, "Oh no, I can't lie on my back." So that, but that's not so much age dependent as it is more orthopedic. But I don't think there's any age requirement or restriction.
One more for you, Dr. Goldstein. There's this also has been asked a couple of times. So if you've had DMEC surgery a while ago and the transplant is not responding, is cell therapy an option?
So again, for the trials, we've excluded those patients, but there's no reason that and the reason again is to get consistency of data. But there's no reason that cell therapy can't work after failed DSAC-DMEC or failed penetrating keratoplasty.
Dr. Salas, this is for you, trying to manage as many questions as I can in the next couple of minutes here. Is there any indication or particular ethnicity that is more prone to Fuchs?
Not that I know of. I mean, the textbook answer to that is that Western Europe has a high preponderance of it, but then there's also another big population in Japan, and they seem to be actually, some people argue they're distinct diseases, and that the genetic underpinnings are a little bit different. I think what we'll find is over the next decade, as we go into even the next phase of cell therapy, which is kind of brought up a little bit in the chat, which is, genetically customized cell therapy, that will have the ability to edit people's genes and kind of get away from this whole idea of transplanting someone else's, but you kind of get your own fixed stuff that's from you, but it's fixed. And to do that, that's going to take some genetic engineering, things that are above my pay grade in terms of how smart I am, and what you need real smart people to do that stuff. So yes, it's a very heterogeneous mixed group genetically.
Thank you. And just one more point of clarification. The cells that we use for corneal endothelial cell therapy are harvested from a donor cell, or cornea rather, and we do not have any data with or experience with harvesting your own cells. Dr. Goldstein, any additional comments on that? That came up a couple of times.
Yeah. So yeah, we're working with donor corneas, and the advantage of that, it's scalable. So we can treat, as I said, 1,000 patients or more. If we had individual patients, it would never be scalable because you'd have to get the cells, grow them, put them back in. The process would never be scalable. So there's a huge advantage actually of using donor corneas. And the other question I just want to address quickly is people asked about stem cells. So we're not talking about stem cells. So stem cells have a lot of advantages, but the advantage of what we're doing and the advantage of endothelial cells is they're already terminally differentiated cells. So they don't have to learn. We have a stem cell, it's got to learn to be an endothelial cell. And some of those cells will learn it and some will not learn it. If they don't learn it, they can actually keep proliferating and you can get other side effects. So the advantage of this approach is it's a terminally differentiated endothelial cell. We get it to a state where it's proliferating again. We take it out of that state, and that's when we inject it into the eye. So there's no risk of the cells proliferating and doing something, off target. So with this particular disease, I do not think there's a large role for stem cells. There's a large role for stem cells in other eye diseases, but not in this particular disease.
We have not selected the sites for our phase 3 trial. And also we have not fully developed the protocol for the phase 3 trial. So if you're interested in participating, please write to us so we can keep your information at hand, and we'll certainly inform you as we near the phase 3 trial. I do want to thank Mary Dennis for potentially giving us the next topic of webinar. She had asked, please explain a phase 3 trial. So Dr. Goldstein, maybe I'll have you do that in less than 1 minute, and then we'll probably build the next webinar, Monica, if okay with you, in educating patients on what a clinical trial is, what the phases of a different trial is, enrollment, informed consent, and all of that fun stuff that the general population just typically don't know.
So yeah, I'll try to do that very quickly. So when you are testing a drug, the first test is to do preclinical testing, which is typically in test tubes and then in animals. Then the first trials in humans are called phase 1 trials, and they're sometimes done in healthy volunteers. And you're really looking for safety signals. The next step is a phase 2 trial, which is usually done with patients with the disease, and you're looking to figure out what's the most appropriate dose. From those phase 2 trials, the final trials are called phase 3 trials. Phase 3 trials are where you're taking the population you're interested in. You've already figured out what drug dose you're typically going to use. They're typically bigger than phase 1 or phase 2 trials. And based on the results of that data, that's what you usually submit to the FDA, and the FDA makes an approval based on your phase 3 trials. Most drugs typically need to go through 2 of those phase 3 trials in the United States, the exception being orphan diseases, which often only need 1 trial. So that was the drug development pathway in 1 minute or less.
Job. Nice job. To answer one of the questions on the chat thread, the donor corneas that we use for either DMEC, DSEC, and certainly cell therapy are very carefully analyzed, and they have to meet a particular criteria for use. And no, they do not have Fuchs. They have to be healthy for transplantation. I think that's primarily it. Just one last administrative component. I know certain people are asking where they can access the recording. We will go ahead and make that available, and Monica will reach out to the group through the Fuchs's Friends thread and give you access to the recording. As I said, please feel free to reach out through the Fuchs's Friend thread, and then also reach out to us at hello@orionbiotech.com. Please visit our website, orionbiotech.com, too, for additional information on our progress. And we thank you so much. This was such a highly attended seminar. We thank Dr. Goldstein, Dr. Salas, for your very well-balanced discussion. And as always, Monica, you're certainly doing God's work when you're informing the patients on Fuchs endothelial disease. Certainly there's a great unmet need here. And I think all of our objectives are the same, is just to get this out to as many patients as there are in need. So thank you all so much.
Thank you.
We'll see a session.
All right. Listen, thank you very much for doing a terrific job. You did outstanding. Absolutely outstanding.
Thank you.
You're in my telephone book forever.
Eris, looks like Eris dropped off, but yeah, thank you. Thanks for allowing us to do the presentation. It's great to see so many people actively involved and asking there's a lot of really good questions on here. So
Good, good.
I'll put a list of all the questions in a log just as a record so that we can keep those handy. But we had 233 participants, not including ourselves. So out of 300 who registered, we had 233, which is a really great turnout. So
Yes,
good.
we did.
Yeah.
We got a good turnout.
Yeah,
And I'd like to see a list of those questions if you have any interest.
Yes, I'm going to see if I can print them without having to retype them all, but I did take photos of all of them.
Okay.
Are we going to answer all of them? Is our intention to answer all of them or no?
We answered about a third of them in real time. You answered some of them verbally. So hopefully any lingering questions will come through hello or to Monica, and then we can address them one by one.
All right. Okay. Thanks,
We did
Krista.
fairly well.
All right.
We tried.
Yeah, it was great. It was great. Thanks,
All
Dr.
right.
Salas. Amazing job. I love the ring light. We'll get those for all the speakers moving forward.
Okay. Thank you. You're in control, so you can close.
All right. Thanks. Thanks, Monica.
Very
Thanks, Paul,
rarely
down
do I
there.
leave anyone control.
Yeah.
But okay, bye.
Bye.